but also that confidence interval is close to 1, so but it was a 1/6 reduction. But cord clamping is not just early or deferred. There's also what we call intact cord milking, where the placenta is left intact, and we can strip the cord, bringing blood from the placenta to the baby, and cut cord milking, where you leave some blood in the cord, and you then strip the cord back into the baby, and you keep away from the cord to do that. So it makes the whole situation very complicated, because now we have at least 4 methods of cord management. And actually, there are several methods of cord management, and I sat down one day and drew a diagram of all the possible methods, and what it turned out is you can have early clamping, clamping to resuscitate, late clamping, and you can have babies with no resuscitation needed, and those who may require resuscitation before or after clamping. And when you add that up, there are at least 9, if not 11 different options for cord clamping. This makes the meta-analysis of studies extremely difficult. And even if you prove that one is better than the other, how do you know that the third is not better? So it becomes an even more complicated algorithm to try and decide which method of cord clamping should be done. Now, Seidler, as part of an arrangement with ILCOR, did further meta-analysis, but they looked at the many different types of comparisons that currently existed in the literature. And their conclusion, and I'll go through what they found for each comparison, their conclusion was that delayed clamping appears to be associated with some benefit for infants born less than 34 weeks. Cord milking needs further evidence to determine potential benefit, harm, and ideal cord management strategy for preterm infants is still unknown. But early clamping may be harmful. That was their conclusion. So comparison 1 was the traditional comparison that we saw in the first Obesity trial, which was delayed clamping versus early clamping. You remember there's a few more studies and a few more infants. And the Seidler group looked at babies under 34 weeks, not under 37 weeks, remembering that these late preterm babies might be a little bit different. And when they looked, and also taking into account that families may be more interested in survival than mortality, they analyzed the primary outcome as survival to discharge, as opposed to mortality. And what was interesting is when they did that, they found a sort of 2% increase in survival, but the confidence interval touched 0. In other words, touched no difference, which was a very difficult result to deal with and a difficult conclusion to make. Remember that as we move forward from Fogarty to Rabe to Seidler, we're getting less and less survival benefit, which is apparent survival benefit in the meta-analyses. So as a post-hoc analysis, they then looked at mortality and actually found no significant difference, which was even more telling. And it'd be interesting afterwards to discuss how this can be. They found no differences in maternal outcomes. So none of these meta-analyses found differences in maternal outcomes. So remember that maternal outcomes, adverse outcomes, are rare apart from postpartum hemorrhage. So they're rare outcomes like maternal death. So you would need very large studies to demonstrate adverse maternal outcomes, but no significant difference was found with limited data and limited numbers of evidence. No clear differences were seen in severe intraventricular hemorrhage, necrotizing enterolitis, chronic lung disease, or in hypobilirubinemia. This is very important in the preterm population. We've not been able to show a difference in hypobilirubinemia in the preterm population. But it probably increases early highest hemoglobin in hematocrit, and there's probably a benefit in higher mean airway pressure and less inotropic support. So there is some benefit in delayed clamping, but the benefit seems to be shrinking over the years. Comparison 2 was intact cord milking. That means that the cord is still connected to the placenta versus early cord clamping, over 1,000 babies and 13 studies. And that found a similar 2% benefit, but the confidence intervals did not cross. It did cross 1, so it was not statistically significant. No difference in maternal outcomes, no difference in those key There's important outcomes or critical outcomes, and same again, a probable increase in cardiovascular outcomes, which should be short-term in the neonatal birth rate. Comparison 4, I'm jumping to comparison 3 because that was a cut cord milking, and there was only one study with 60 babies, and it wasn't significant, so that was not, so we're not reporting those. But delayed clamping versus intact cord milking, there were 7 studies, also over 1,000 babies, and there was no difference between delayed cord clamping and intact cord milking, and no difference for any of the other outcomes. So intact cord milking and delayed cord clamping look the same. Comparisons 5 to 8, which were these delayed cord clamping versus cut cord milking, etc., and in particular delayed cord clamping versus just leaving the cord. There were no studies were identified in preterm babies to answer that question. So we just don't know. So in summary, for survival to discharge, delayed clamping may be the same or better than early clamping. Intact cord milking is not different from early clamping. Intact cord milking is not, actually significantly different from delayed cord clamping. And what's not significantly different means you can't exclude benefit of being identical. And for some important, but not critical outcomes, as cardiovascular and hematological, delayed clamping and intact cord milking may be better than early clamping. And there was nothing in terms of maternal outcomes. So a post-hoc analysis was requested because, you know, we had so many questions about the Simon study, about all these secondary outcomes. And basically the important ones that we requested were less than 30 weeks versus 30 to 34 weeks, high income versus low and middle income countries, resuscitation before cord clamping versus after, and the timing of clamping, like should it be 30 to 60, 60 to 1 to 2, and basically we were unable to identify any significant differences. There were significant differences, but none which made a difference to the final conclusion. Now, what happens then in ILCOR is we do a justification and evidence decision framework. Now, this is available as a draft form. If you go online to the ILCOR website and search cord management, it's there. It's been up for public comment. So that's the level of publication where it's at the moment. So it may change, or the wording might change. But the justification and evidence, it's very interesting because what that means to me is we're now allowed to assess this using our biases. So you introduce a bias at this stage, and I'm going to talk about that later because our biases are really important in how we manage guidelines. So the findings suggest neutrality between in survival from delayed benefit on neutrality in survival. When you compare delayed cord clamping, no findings in other critical outcomes, important benefits in hematological and cardiovascular, no differences between delayed and intact cord milking. But there was one study which by Kathiri in 2019, which actually demonstrated what's called a signal for harm in babies born less than 28 weeks. There was a spike in intraventricular hemorrhage from intact cord milking. And that's something which led to a deviation from the recommendation, which is still under some debate. And there were no conflicts in the post-subgroup analysis with the final conclusions, and insufficient data to discuss what might happen if a baby immediately needed resuscitation. Now, I'm going to talk about this context of values and preferences and how we make recommendations. As you know, we use the grade process for recommendations in ILCOR, and you can only come up with 5 possible conclusions for a recommendation. You either suggest 4, you suggest against, you recommend 4, or you recommend against. And rarely you can say, I'm unable to make a recommendation, there's no evidence there, and that should be rare. So, in the real world, we have to make a recommendation. Aristotle has this quote: a man being just as hungry as thirsty and placed in between food and drink must necessarily remain where he is and starve to death. And no neonatologist or resuscitator wants to starve to death between should I delay clamping or should I clamp early. So we have to make a recommendation. It can't be that we leave it up in the air. It's too important to find it. But what recommendation you make depends on which universe you live in. And we live in 3 universes at the moment. We live in this Edward Scissorhands universe. Snip, 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 and it's done. We don't have to wait. We live in the wait and see universe. We just wait and see. And we live in the Milky Way universe. Milk the cord and then do whatever we want. Early or late, there's so many combinations. So if you were to look at the Seidler paper and the other papers, and you were living in the early clamping universe, you would say, oh, we should think about changing our minds. But if you lived in the delayed cord clamping universe, you would say, well, we're in a good place. And you could make a stronger suggestion. And if you lived in the Milky Way universe, you might say, I need more evidence. One study doesn't stop me from doing that intact cord clamping on the babies under 28 weeks that we've done all these years. So how we make a recommendation depends on our culture and where we are, which is a paradox because we go to all this trouble to look at risk of bias in our clinical trials. So the recommendation, it's a draft recommendation from ILCO, is infants born less than 34 weeks gestation do not require immediate resuscitation after birth. We suggest deferring clamping the cord for at least 30 seconds, weak recommendation, low certainty of evidence. The word suggest to me means it is possible in 5 years' time, something different will come out. That's what it means to me. Whereas recommends to me, it's much stronger. It means we don't need to do any more studies now. It's a done deal. So we're staying with suggest. In infants born at 28 to 33 plus 6 weeks gestation age who do not require immediate resuscitation at birth, we suggest intact cord milking is a reasonable alternative to deferring cord clamping. This is a weak recommendation, moderate certainty of evidence, and it does not mean that there's an algorithm which goes, I'm not going to delay clamping, I'm never going to do intact milking. We just have identified that in that population, it's the same, that the outcomes are the same. We suggest against intact cord milking. It suggests against, which means more data might be available in 5 years' time to answer this, which means the studies should go on. It does suggest means you need more studies. Against intact cord milking for infants born at less than 28 weeks gestation age, weak recommendation, very low certainty of evidence. If we stop doing studies because somebody suggests something, we wouldn't do any studies. We just couldn't, because every suggestion would be a done deal. And that's a very important factor for the lawyers to understand. Infants born at less than 34 weeks gestation age who require immediate resuscitation, there is insufficient evidence to make a recommendation. We were forced to do that, we just don't know. So there's other pieces, insufficient evidence. This is a really important piece, like diaphragmatic hernia, should we delay clamping? Congenital cyanotic heart disease, should we delay clamping? There are a whole load of conditions that we just don't know. We think more studies are needed before we can make those recommendations. There are some gaps. There's a real gap in the nomenclature. Now that there's so many options, we need to get it right. And we need to think about where we're going to put, what words we're going to use. And this needs to be a national or international strategy. We need to really get these answers because it's a public health strategy. Everybody born in the world is going to be exposed to this. And there are insufficient data. I've already talked about congenital heart and lung disease. I wanted to go on just a little step further because we need to translate what we're finding in meta-analyses from ILCOR into AHA, into NLP. And these are the AHA recommendations. And I really like the AHA, I'm biased obviously. I like the AHA recommendations because they allow a nuance of language. It's not just suggest or recommend. You can use increasing strength of language. So here we're saying it's reasonable to delay cord clamping in preterm baby for longer than 30 seconds. And in term infants, it may be reasonable. And that's because the level of evidence is different in preterm babies. It's randomized controlled trials. In term babies, we're actually saying there's there's limited data. And then we go on to make recommendations, which the important one I want to point out is for infants born at less than 28 weeks gestation, cord milking is not recommended. But look at the evidence, it's recommended at no benefit as opposed to harm, because we really think that maybe too far, and we're not sure. But that's an important point. So then we have to translate the AHA guidelines into practice. Translating into practice requires quality improvement methodology. And this is a run chart. This is a run chart of what we did in 2008 when we introduced delayed cord clamping in babies under 33 weeks gestation to our institution. Things don't happen overnight. Delayed clamping is a culture change, or cord management, I should say, is a culture change. And you can see that in, what do you think happened in July, guys? Those of you who are residency program directors, right? You can see that we started off really well, our obstetricians were really good, but then we realized it's the residents who are reminding them that we're delayed cord clamping. So until we orientated our residents, we didn't get back up. But we're hovering around 60 to 90% for our delayed clamping under 33 weeks. Also, what we did do was we didn't want to challenge people too much. We started with babies from 28 to. So our PDSAs vary depending on where we were in our quality improvement cycle. Time to say, yeah, it varied. And you can see that we added the 29 weeks, and that didn't make it worse. It actually continued to improve our. So you can see it took us 22 months or whatever to get to a stable level of delayed cord clamping. We knew that it would never be 100%. There are ineligible babies, there will still be contraindications. And we actually also audited all our balancing measures. So what we did do is we looked to see whether the non-compliant and the compliant were the same first, and they were in the gestations of birth rates, whether C-section, and whether they survived or not. But we were really interested in whether it would affect admission temperature and initial hemoglobin. It did affect admission hemoglobin, and it did affect admission temperature. And the babies with delayed clamping actually had a higher admission temperature and had fewer. 19% who won the 36.3 and 30% in the no delayed cord clamping group. And there was a difference in neck or perforation. I don't know whether that means anything, but otherwise everything was the same. The bilirubins were identical. Maximum bilirubin was identical. 2 points. I just want to come on to late preterm birth in the last 5 minutes. And I know many of you are more interested in the term late preterm birth because it represents a larger proportion of the population. But sadly, we don't have much to say about late preterm births in terms of the meta-analysis, because evidence for all outcomes was low, very low. It's 46 studies with almost 10,000 patients and 9 comparisons. And compared to early cord clamping, placental transfusion strategies probably improve hematological measures, but may not affect survival without disability. So there isn't much to say that. No difference in major neonatal internal morbidities, and strategies to promote increased placental transfusion may be associated with greater therapy use, but really that's in a subgroup, and the difference may not be significant. So that's ILCOR, the draft ILCOR statement says for term and late preterm infants born greater than 34 weeks, greater than equal to 34 weeks, so vigorous or deep, to not require immediate resuscitation. We suggest later delayed clamping cord at greater than or equal to 60 seconds. It's a weak recommendation, very low certainty. So there's more work to be done here on the evidence side. So I hope I've suitably shone a light on a very, it isn't really a cloudy night, but there's just too many stars at night. And shining, when I was a kid, I used to shine a flashlight at the stars, thinking someone would flash back at me. And we used to see the stars like this in Africa. But Thank you very much for listening to. I hope it was helpful. I look forward to any questions.
Thanks so much, Khalid. It's a difficult subject, and we have our distinguished discussants to join us today. The first one is Nathan Sundgren. I'm going to ask him to come join me on in our living room up here. And Nathan is an assistant professor of pediatrics at Baylor College of Medicine and associate medical director of the NICU at Texas Women's NICU. And he was and the program director for our Neonatal Resuscitation Program, and we've already he's already offered questions and opinions in the session this morning. He was trained at Oregon Health Sciences Center in university, and he got his MD and his PhD there, and at Southwestern and Parkland Hospital for residency and fellowship. He's been primarily interested in quality improvement and in delivery room care and human factors in resuscitation. He's known by some for his tweets and his videos on his YouTube channel. How many of you have a YouTube channel? But Nathan does, about neonatal resuscitation. And we're honored to have him as a discussant today. Welcome, Nathan. And on our screen, you see our second distinguished consultant and a discussant, Tansi Raju. Hi, Tansi, how are you doing? And we're happy to have you here today. Tansi is hard to introduce because if I really told you everything about Tansi, it would take a long time. But he's really had, I think, what I see as 3 episodes in his professional career after he graduated from medical training at Mysore College. He has had a long and distinguished career at the University of Illinois with Dr. Vidyasagar and that group. And he was an ICU medical director there for a long time. Then he spent, that was the first 25 years, and then he spent 2 more decades as the chief of the pregnancy and perinatology branch at NICHD. And I think all of us remember how much Tansi supported resuscitation research and people who were trying to do, he mentored people in that kind of research when he was at the NICHD. Then now he has a 3rd career as a deputy editor for Journal of Perinatology and as a director for ECHO ISPCTN. I think I got it right, Tansi. And he's going to tell us a little bit more about that later for NICHD. And Tansi's long been interested in transitional circulation, and one of his early lectures really inspired me in this area, and I've always given him credit for that personally. In his spare time, Tansi writes history pieces about medical history. But today we won't go into that. We will stay in the present and ask him to discuss neonatal transitional circulation and cord management with us. So let's start with Nathan with some practical questions about cord management.
Well, just want to thank Dr. Aziz. That's a great review of the delayed cord clamping, some of the questions. Something you didn't touch on, I sort of have maybe a 2-pronged question, but I kind of need to hear your answer to the first prong before I can ask the second. And that is, we didn't talk about the potential neurodevelopmental benefits later and what your take is on that current literature, both in preterm and term babies.
Right, I think the probably the term baby is the most challenging one to answer. So I'll answer that first, but Tansi, I'm sure will have some thoughts on that. So most of the iron that you get in infancy, you get at birth, it's in the hemoglobin that circulates. So theoretically, delayed cord clamping should improve your iron stores, and that should last not just a few hours or days, it should last into early infancy. And actually, one of the subgroup analyses in the Dolosol study did show that there were fewer low ferritins in infancy. But the real test would be, does it improve the longer-term neurodevelopmental outcome? Because when you look at it in the world, this is a major public health question. It's a major question as to whether we can reduce iron deficiency, anemia. Actually, it's not anemia, it's the saccharones, it's the brain enzymes as well that need iron. Whether delayed clamping has a benefit in terms of neurodevelopment through its effect on not just iron, but also stem cell infusions, etc. We don't know that answer. We just, many of us believe it to be true, and it needs to be tested. And I'm not sure how it would be tested now that the universe has shifted from an early clamping to a delayed clamping universe already. But I think that it's an important scientific question as to whether it should be, and all we can answer about it is it may be, it's hypothetical, but the studies aren't out there to confirm. With the preterm baby, that's a little bit different, because the question is, there's a change in cord management strategy reduce or increase the risk of not just, I mean, intraventricular hemorrhage is one type of injury, there's ischemia, there's apoptosis, there's PBL, there's all sorts of things that might be happening in the brain in a preterm baby's brain after birth. And we really don't have a good handle on whether that's the case. The deformity. There was initially a signal to say it might prevent brain injury, but I think we need a little bit more data to be sure about that. What I would say is, in which university you live in should probably be influenced by nature, and therefore a more natural approach should be the control, and the intervention should be the medical intervention. And that's not the way we've worked it, because you can see we use the control as a immediate platform. So your second question.
So you're hitting on some of those already. So I was trying to think, so I'm one of those that see the data for potential neurodevelopment, and I'm very hopeful that that ends up being true. I agree it's not overly convincing at the moment. But then I struggle with the mechanism, because as you said, with the preterm, there was sort of this obvious, well, if we decrease IVH, surely we're going to do it, but we can't seem to, we haven't held on to the IVH benefit. And then when we talk about terms, we think about these iron stores, and I think that's, you know, a lot of this data you showed, pretty consistently, we can find this increase in hematocrit and hemoglobin levels and iron stores. But then there was just recently a paper in a randomized trial that did 3-pronged arms. There was a control, placebo control, a liquid iron formulation and a mineral iron, a powdered iron formulation. Remember, not exactly where, remembering where in Africa, but it was iron supplementation quite early, like 2 or 3 months of age for many months. And then the follow-up was the Bailey scales at 2 years, and there was no difference between either the outcomes. So my struggle is in not knowing well enough yet, how strong is this correlation between iron stores and iron to potentially even have that neurodevelopmental outcome? Because here's a study that really did target exactly that intervention, increased iron, but there was no improvement in the Bailey scores in neurodevelopment. And that seems to unhinge our plausible physiologic reason this would have any help.
Yes, I agree with you. It's like the sustained inflation. It seems so plausible that it should help, and then we discover it may not be helpful. And one of the problems with randomized trials is you're actually looking at something which is extremely multifactorial, development at 2 years of age, and has significant variation in human beings, and you're making one intervention. So the jury is out in my mind about this, but they're on the side of saying that, and this is a bias, it's not scientifically based, that interventions like immediate clamping, which are synthetic or not natural, if there's equipoise, we should probably err on the side of the natural intervention. Whatever that might be, we still haven't worked it out yet.
Okay, Tansei, what's your comment and questions to bring into this conversation? Glad to have you here.
Yeah, thank you. First of all, thank you for the invitation. And Khalid, you gave a great presentation. Thank you. Concerning iron deficiency and delayed cord clamping in term babies, I think it has a tremendous significance in the developing world. Rest of the world, as you know, iron deficiency is a huge problem. And there are lots and lots of studies to show that iron deficiency does affect both not only developmental outcome, but also higher rates of infection. And so there's a lot of connection of benefit, potential benefit, even for term babies of iron deficiency from the delayed cord clamping. There's a question in the chat box asking, some obstetricians apparently tell them that there may be microthrombi. That is not right, because it is the same placental blood that is going to the baby that was going inside the uterus. So there is no microthrombi I can imagine, something new that comes up just because the baby came out just now. So that is not going to be a reason for that. Just to add a bit of history that you nicely talked about, why did the immediate cord clamping came about? And my thinking is, it is in the early 20th century when more and more women began to go to the hospital. Before that, midwives were taking care of moms in labor and delivery, and midwives are a lot more calm and as compared to our obstetricians, and of course, totally calm neonatologists, as you know. Since more and more of us began to attend the delivery room, obstetricians said, pediatricians said, give me that baby. And then we were more confident about resuscitation. And so the obstetricians want to get rid of that baby and give it to you. So I think it came in without any evidence. So really, when we talk about convincing our colleagues or obstetricians, my way of asking them is, what is the benefit of immediate cord clamping? Rather than saying, is there a benefit for delayed cord clamping? So immediate cord clamping has never been really tested. It came into practice without testing. So for centuries, it was always a delayed cord clamping. And so I would ask that question, but your presentation was excellent. Thank you.
Actually, I can tell an anecdote related to that, because I know we started delayed clamping in our institution like 15 years ago almost. And it came about because family practitioners and midwives came to us as neonatologists and asked, why are we clamping early for meconium if it's no longer necessary to immediately intubate? And that started the whole discussion around that. And that led to us looking at the trend, and actually because we were a high-risk preterm unit, asking the question, why were we clamping early in preterm babies? And that led to an ecology improvement initiative.
I just want to also add, that a terminology, people never like to say anything delayed. We always want to get everything right away. So when you said delayed cord clamping, hey, why you want to delay anything? So that is a common way of thinking, unfortunately.
Okay, Khalid, I thought it was a very interesting talk and presents the difficulty of looking at the literature and coming to conclusions. It seems to me that we saw from Peter Davis's talk and sometimes from our own experience that babies who don't need resuscitation, and especially the term ones or near term ones, take a breath right away. And even when you do immediate cord clamping, they've already taken their breaths. And we know that we know that much of the placental transfusion occurs within the first 2 or 3 breaths, is what Peter did say this morning. So it may be that our timing of what is early and what is delay it may be too late or too soon, or maybe it's different. And the other thing is it may be different in different situations. And this whole thing about breathing before cord clamping, I think is a question that's being answered in some studies that are going on right now, the Vent First study. So would you comment on what is the appropriate timing, and how do we divide the literature depending on when the cord was clamped and when the baby breathed?
Right, so both the Gonzalo and the Cyber studies, there were post-hoc subgroup analyses of the timing, and they didn't really show a big difference in timing. That's in any of our critical outcomes. So I would start with that. I may stand corrected because I wasn't as closely involved with the term study. So I don't think there's a significant difference in timing. I think that, and the reason the times were chosen was just because that's how the studies fell out. That's what the researchers did. People often ask us, well, why did you choose 30 seconds or 60 seconds? It's just that's how the studies fell out. In term babies, they tend to be longer, and in preterm babies, it tends to be shorter. So I would come back to, actually, Tonse and I are on the same page on this, that there's, in nature, the circulation continues. And the heart fills with blood returning from the placenta. And one has to ask the question, is the intervention of stopping that exchange of blood, which has been going on for millions of years, is the intervention a good intervention? I'm in the leg clamping universe, I have to say. But, so we need to, I don't have an answer for you, but we need to answer that question if we want to continue clamping early.
Do we have any questions from the audience or from the chat?
We have a question from the chat from Linda Chu. Can you comment on the position of baby relative to perineum prior to cord clamping? Is it not significant enough to affect outcome?
Right, so I think the study is by, I think it's by Nestor in 2014, where they actually randomized babies to below and above the introitus. Didn't show a big difference from a 40, plus or minus 40 centimeter variation. It appears that there's different reasons why the blood goes back and forth. It goes both ways, so it goes back and forth between the placenta. People's ultrasound on the cord to show that it's going both ways, but in both vessels sometimes. So they're probably, in a baby who's actively breathing, one of the other mechanisms of transfer is the negative intrathoracic pressure when we take a deep breath. We got this higher hemoglobin, and in preterm babies, half of those are C-sections where the baby is going to be above the placenta and is going to be lying on another side than the normal lap. So I think the height at which a baby is probably, and this is a supposition, I'm going to just say that it's probably only significant if the baby is completely active and there's no respiratory effort. That's my thought. Maybe, as Peter says, maybe if you have high thoracic pressure from ventilation. But I think when you have lung disease, that's not transmitted to the circulation. When your lungs are stiff, there's a gradient between the airway. So, but there may be somebody in the audience who has an answer to that, who has studied it or has an animal physiology answer. I don't know whether I've answered your question.
Okay, let's move on to a question from the audience.
In line with the beta neurodevelopmental outcome, we know that we can get a beta arterial pressure is delayed for clamping, and by doing that, we can achieve like a beta cerebral flow regulation, and we can avoid which which can come after like volume and preserve resuscitation of those babies. So can we think that way? That for clamping can prevent or give beta.
That's a good question. It's significantly shown in the meta-analyses and also in quality improvement studies that, you know, the rate of use of inotropes in preterm babies who had either delayed clamping or milking is lower. I mean, in our sense, I think it went from 13 to 88%, but it wasn't significant. But that is the drop that we see. The use of inotropes is yes, the use of boluses is less, the use of transfusions is less, and quality improvement, observational studies. So the question is, does that translate into reduction in brain injury? I don't know the answer for certain to that. It depends, you know, the hypothetical causes for brain injury. The injury might have already occurred, and that's why we've got the loss of autoregulation and the need for inotrope. So it's actually difficult to know whether it will translate, but it would make sense that if you're needing less intensive care, you should have fewer complications. But I don't think the long-term data, you know, the meta-analysis.
I think to that point that you're making is where I think there's, again, you talked about the multifactorial nature of any neurodevelopmental outcome. So certainly all those things can contribute. And I think that for me, the preterm birth sort of camp under the stability and transition that is most easily demonstrated in the animal models by Peter Davis and Stuart Hooper in their lab, that way different in the transition and the way the stability of the physiology that occurs there. I happen to believe that has something to do with whatever benefits we're seeing, as well as maybe the blood volume. In terms of the height or things like that that might affect placental transfusion, that's, you know, one of the first papers I looked at was around in 1969. I think it was called Yao and Lind were the two authors. At some point, height matters. So you want to hold a baby up, you know, 100 centimeters above the placenta, he's not going to get as much blood. And they did that. They had this really high and then they went really low. But in that range of that plus minus 40, it doesn't seem to make a whole lot of difference. So whether you hold the baby right at the perineum or lay on the mom's belly or chest or try to drop them a little lower, you're probably not making much difference. But if you hold them up over the curtains to show mom on the other side of the C-section, probably not a good idea. And we run into that sometimes.
So,
Okay, Chauncey, what do you want to say?
yeah, a couple of quick points. Teleologically, amongst all the primates, humans have the longest umbilical cord. And one of the explanations is that before we had doctors, there were mothers and there were, you know, other people helping. And as soon as the baby is born, the mom can pick up the baby and put the baby on her chest and the baby starts suckling. That benefits the placental separation. And as you know very well, there's oxytocin release from baby suckling. So from an evolutionary perspective, delay in the cord clamping or separation was built in our nature. So the early clamping itself is an artificial introduction. Anyway, so that is a point I just wanted to make. The other question on the other side of the issue that I want to ask maybe Aziz's opinion is Katheria's trial below 28 weeks cord milking that led to increase in early, especially early intracranial hemorrhage, that to severe early intracranial hemorrhage that led to the, you know, stopping the trial for that group and then changes it. So a lot of people keep saying, well, just because of one trial, do you want to change your practice? And my answer to that is yes, if that trial is done very well, and this is one of the very well conducted, you know, randomized clinical trial. And I'm still debating as to why did he end up finding that finding? What may be the physiological explanation? Do you have any insight into that, Aziz?
Actually, thanks for that comment. I just wanted to say that clinical trials are really, they can be a little bit, I don't know what the word is, perverse, because you choose the patients who are least likely to have the complication to be in the trial.
Right.
Because you have to, they're sitting there, they have their steroids, and you know, that is one of the problems. And even when you look at our observational study, which I showed you the slides, 1/3 of the babies were not eligible for delayed clamping. And when we looked at that population, they were the group who had all the complications, the mortalities, and so the ones who weren't eligible because they had abruption or sick mothers or abnormal placentation or placenta previa, they actually were the group that had the highest morbidity. So when we, and mortality, so when we look at clinical trials, we are looking at a selected population where it may make no difference whether you have early delay or milking. So that we always have to think of delayed cord clamping that way, that it may not apply to the real world of people who are most likely to get the brain injury. Having said that, then we go to the Khalid study. That study was stopped, and I know there's 3 other similar studies, and when you look at the meta-analysis of them all, it shows no difference in intervention. I agree with Thomas's observation. I don't know how to answer it. It depends how risk averse you are. That's the answer to that question, depends on your culture. In a risk averse or litigious population, don't do it.
Okay, let's have a question from the audience.
So thank you very much for your talk. So I think Dr. Escobedo mentioned that, perhaps in different scenarios, different amounts of delayed cord clamping would be required. And that potentially the reason for that would be that different babies breed at different times. And so the transition from placental preload to pulmonary venous preload is different for every baby. And I'm wondering if any of these trials or these current trials have looked at, rather than time-driven interventions, so delaying the cord at 30 seconds or clamping the cord at 30 seconds or 60 seconds, rather than having time-driven interventions, having event-driven interventions, in the way that Dr. Escobedo was suggesting, that waiting until the baby breathes sometimes, whether that's 30 seconds, 45 seconds, or a minute, rather than kind of time, and maybe that's also potentially more practical in a place where we don't have timers like we do here at the, at really nicely developed hospitals, but in places where we don't have timers.
Yeah, I would say, I mean, the group in the Dutch group and Dr. Argent Paz based a lot on Stuart Hooper's work. That is exactly what they call it, physiology-based cord clamping. So it's something that, I'm a more simple guy with the NRP, we all get the ABC. So airway, breathing, then clamp the cord. That's the new ABCs, right? You want the breathing first before you clamp. That might take 45 seconds before you get that first breath. So if your first breath is at 45 seconds, do you want 30 seconds from that? Or do you want a minute from that? Picking these arbitrary time points have that problem. But on the other side, if your baby's not breathing by a minute of age, probably leaving him there longer, well, maybe okay, because you've still got the placental circulation intact, but maybe not okay at some point. So I think that's the struggle. And then you get in the struggle, how are you monitoring them through that point? I always feel like the delivery room is one of the few areas where we're the least technological in terms of our guiding principle. We have heart rate. And we have heart rate, and maybe the SAP's working by now 3 minutes later. So how am I gonna know how that baby's doing over there? And then you start to get into the concept of resuscitation on open cord, having your team available to actually assess the baby while we're waiting for the physiologic transition to happen before we finally clamp. But those are daunting. Every time I think about that, it just scares me to the death of the idea of having to put a team scrubbed in the OR. How would the logistics of that work? How many people would I need hands-on the baby? So this potentially is where we really need to go, is this physiology-based cord clamping, but it is a lot more easy to say 1 minute and we're done, right? And I think that's where the evolving science is going. I don't know if Dr. Aziz, you have a different opinion on that.
No, I agree. It is the Goldstone and Seidler group did try and look at physiological versus other methods, because you can imagine there's this massive network of options. One thing to think about is actually cerebral. I mean, maybe we'll have near spectroscopy of the brain and normals for that. And once we have that, we can look at the different techniques of brain of cord management. And we know there's a difference between the different formulation strategies and near spectroscopy. That may be more reliable than what we've looked at to date, but who knows?
Another question from the chat? We've answered our questions. That's amazing. Tansy, any more questions or comments on the cord management?
Can I ask?
Oh, I'm sorry. Here's Virtue. That's a question in the room.
In Bill O's group at Brown, they have demonstrated in 6 days about the redistribution of the blood flow after delayed cord clamping, and it does redistributes by 96 hours. I'm just trying to see that there is that anybody looking at this, like redistribution of the blood flow, which we gain the placental transfusion by delayed cord clamping, and is there any more science coming out of that, especially in the lieu of the cord milking, increasing the IVH in the extremely small premature babies, how to find out the further details and refine the science in this area, so we can have a better neurodevelopmental outcomes in the small, extremely small preterm babies.
Right. You know, it's very difficult to extrapolate from animal data to humans. It's a trap for us as clinicians. But this is I'm expressing a bias. If the brain injury has occurred before birth and you're looking at reperfusion, then we have to be very careful about what we do at the time of birth. So I would say that redistribution from the placenta to the baby the brain might be sensitive to it in some way, and in either positive or negative ways, because you get a significant stem cell transfusion from a placental transfusion. But you also, if you have poor cerebral autoregulation, you get significant changes in cerebral blood flow, I'm pretty certain, from such a transfusion. So I think it's a watch this space. What the physiologists are doing is challenging us to look at new ways of doing things and new ways of measuring.
So the conclusion is more studies are needed and favor physiology, favor nature.
Nature might have got it right.
Maybe so. Okay, well, thank you, colleague, and thank you, Nathan. And let's move on to Tom's short message on the ECHO ICTPN network.
Thank you very much. I think I have sent my slides, so if you can start showing them. I was going to say, yes, you need more studies and you need more grant applications you have to submit to NIH, because if you don't submit, nobody is going to give you an NIH award. So that's how you begin to get that. Do you have my slides, right? Or should I do it myself? Should I share my screen and present my slides?
I'm working on it.
Okay, I have it. I can share it too if you want. I can share my screen.
There it is. There it is.
Go ahead. So while the slide is coming, I can give you a little bit of an introduction. Yes. So the title of my talk is the Idea States Pediatric Clinical Trials Network, ISPCTN. So it takes a while to get that abbreviation clearly into memory. Quickly to talk about this history and future, and this talk probably is more pertinent for people in the United States than elsewhere. Next slide.
You should be able to click.
Okay, all right. Yeah. Okay. Yes. So the program is called ECHO, or Environmental Influences on Child Health Outcomes. And that is a program supported by the National Institutes of Health. And it is located in the office of the director of the National Institutes of Health. So it's a separate program by itself. And it was established in 2016. Let's see, I'm clicking. Next slide. Yes. Oh, sorry. Go back. Yeah, it's going very fast. Am I doing it? Okay. All right. Next one. Yes. The mission of the ECHO is to enhance the health of children for generations to come. Next slide. As it says, it's the environmental influence. So in the ECHO program, we have different components. So in the ECHO office, And these are the two important ones that I'm going to talk today. The idea states network, infrastructure, I'm getting to that in a second. Another one is a cohort. Okay. What is idea state? Oh, that's something that a lot of people may not know, and I didn't know a whole lot about it. The idea state network, Pediatric Clinical Trials Network, established in 2016. And what are idea states? In 1993, National Institutes of Health designated 23 states in the United States and Puerto Rico as institutional development award states. They were designated, or they were picked up, because traditionally they had much lower NIH funding compared to the rest of the country. So rest of the country, typically, you know, the Harvard, the Stanford, Hopkins, they tend to get quite a bit of dollars from NIH. So the Congress passed a resolution, or recommended a program that NIH should begin to focus on these areas, which have mostly rural and very disadvantaged populations. So you need to focus your your research funds to enhance the research infrastructure in these states, so that they also can begin to field good studies that will help address their healthcare needs. Okay, next slide. Only horses. Sorry. Okay, so the idea states Pediatric Clinical Trials Network. The goals were to provide access to state-of-the-art clinical trials and build a national pediatric research capacity to conduct clinical trials, professional development, and help develop infrastructure, so that they can also successfully compete for future funding and address the specific needs of their area, which will of course help the whole country. And there was an announcement and lots of people applied, and in the initial cycle of 5-year funding, there were 17 clinical sites, and the second cycle that just began last year, there are 18 clinical sites. The latest one is South Dakota. All these states are located. Please note also, Oklahoma is one of the idea states, and we have a site. The Oklahoma also participates in the idea states Pediatric Clinical Network research. And there is a data center that is in the Arkansas Medical Science. Next slide. Yes. The salient features of that is, this is the only clinical trials network related to pediatrics in the country, actually, supported by NIH. As you well know, that there is already a neonatal research network at the NICHD, but there is no pediatric clinical trials network. So in fact, this is the first one to start. The ISPCTN's focus area of research are 5 topics, and I'll get to that in a second. And of course, we also help them to build capacity building, and they are largely inexperienced in multi-center clinical trials and sometimes research altogether. Next slide. Let's see. Okay, so the 5 focus areas of health research include pre and peri and postnatal health, upper and lower airway conditions such as bronchiolitis, asthma, and airway disorders, obesity, neurodevelopmental outcome, and then positive child health. So it's not simply taking care of the diseases, but also having a positive attitude towards life and positive health. How do we promote that? So these were the 5 major focus areas for research in the ISPCTN. So how many studies have been completed so far, or have been going on and completed? The very first one is POPs. And if I ask you to expand the abbreviation, you will never be able to do that. It's one of the strangest abbreviations that I know of. It stands for Pharmacokinetics of understudied drugs administered to children per standard care. So this is a program that ISPCTN collaborated with NICHD, they have a pediatric clinical trials network in the pharmacology network. And in that, they addressed, the rarely studied drugs and their pharmacokinetics. So that our participation has completed, and several papers have come out. The other one is the VIDORA, vitamin D pharmacokinetics in children with asthma and obesity. As you probably know, vitamin D deficiency has been blamed for higher asthma attacks, especially in obese children. And this particular study was, first of all, to find out what is the pharmacokinetics among the obese children. And this study is just completed. And another one is a remote intervention for obese and overweight children. And the next one is the ACT Now, that is accelerating clinical trials for neonatal opioid withdrawal syndrome. So that's the next slide. I'll have more information on that. This is also in combination with NICHD, and this is to help end addiction long-term. That's a HEAL program, and working very closely with NICHD, as I said, and Duke is our coordinating center. Next slide. And who is in what? How many states in what clinical trials? And this gives you quickly the vitamin D trial, the 2 sites, and then Eat, Sleep, and Console. You probably know that is many people are using that approach to treat opioid withdrawal, syndrome in babies. And however, remember, ESC has never been really tested systematically. So when we complete that ESC study, it will be one of the largest randomized clinical trials testing the benefits of using that versus the pharmacological therapies. And you see the other 2. All right, next slide. Let's see, I'm here. And lots of things are happening in the cycles 2 that just started. And there will be 3 new trials, and I will, I cannot tell you now because they have not yet started. And then there will be 5 junior investigator pilots. So they will be funded, and so stay tuned. So the last few minutes, I will talk about the other component of the ECHO program, that is the ECHO cohort study. That is absolutely fascinating set of studies that's going on. These are all observational studies. And as we talk about, ECHO cohort studies are coming from anyone in the entire country who has already done a study in children, and they have a pre-existing large cohort. For those cohorts, this particular program funded money so that they will continue to follow up those children and study the effects of environmental exposures on outcomes. This is fascinating because this will be a solution-oriented questions will be done. There's a broad range of early environmental exposures on child health outcome. When we talk about environmental exposure, it is not simply the toxic, fumes or pollutions, but it's an entire environment during the development. So that is shown. We know that early exposures have long-lasting effects. Development is very highly integrated process and sensitive to time of exposure because children have rapid growth, active and extensive cell differentiation, their metabolic rates are high, and their immune system is developing. There is a programming that goes on. So all these factors will affect what would happen long-term. So when we talk about environment, as I said, it's biological, behavioral, psychological, medical, social, and physical and chemical. So all kinds, starting from pregnancy through childhood and beyond. So what are the effects? So it's a national-wide program, ECHO. There are 31 awards that have been made, and these are all the states that have the ECHO program sites. And compared to ISPCTN, and if you add them together, the ECHO program has an influence in a very, very large number of states in this country. So stay tuned for fascinating results to come from these studies. And these are the 31 institutions that have been funded from the ECHO. Some of you in the audience may be able to see your site is listed also. And these sites have sub-awards. So actually, totally, there are 72 principal investigators. That's a fascinating group of investigators. And this whole platform now, 90,000 participants, including 57,000 children's data are available. And so very wide, diverse group, and there will be biospecimen, thousands of biospecimen that will be made available for outside people as well. And it is a kind of a weaving pattern. So you take the entire cohort and hopefully try to answer very difficult questions that cannot be answered from just doing a randomized clinical trial. So this is the foundation through which many advances can come through. And so this is my last slide. So the entire idea of the ECHO program is to enhance the health, improve the health of our children for generations to come. And once again, my sincere thanks for the invitation. And Marilyn, you have been very helpful inviting me, and fascinating to see you all. And thank you. I don't want to stand between you and lunch.
Yes, it's time for lunch, and we'll forward any questions to you from the chat when they come in. So thanks again, Tati, for being part of our program this morning. We really appreciate all your information, and we'll try to keep those grants coming, those grant applications coming.
Yes, please
Thank
do.
you.
Take care. Bye-bye.
It's our lunch. We have our lunch break until 12:45, so let's eat.
Bye.